Good evening, everyone. I'm Dr. Jeffrey Farmer from Fox Chase Cancer Center. I want to welcome everyone to our Together Facing Melanoma event, and I'm really looking forward to it and allowing us to share our knowledge to patients, caregivers, advocates, and guests. And thank you all for joining us. I'm the chief of the Division of General Surgery at Fox Chase. I'm a professor of surgical oncology, and I'm the surgical director of the melanoma and skin cancer program at the Fox Chase Cancer Center. Tonight, my colleagues and I look forward to sharing with you the latest research and treatment developments for melanoma. Although we wish that we could be in person for this event that we've done historically, we hope that you can find this program inspiring and informative from wherever you're joining us. And with this virtual kind of arena, we hope that you can share this online in social media. It's not just one event, so it can continue, and we hope that other friends and family can look at it at a later date if they're not on live. We encourage you to leave questions in the chat feature throughout the program, and we will get back to you later in the evening and in hopes of answering those questions either during the event or afterwards on Facebook Live. At our Together Facing events at Fox Chase, we traditionally begin with honoring those that I just want to take a few moments, if everyone could just please join me in a moment of silence. Thank you. I'd like to also take a moment to thank our exhibitors for sponsoring this event. It's wonderful to collaborate with such great organizations that allow us to do new research studies and kind of really improve how we take care of patients in all stages of melanoma and cancer. It's because of their generous support that we can offer this free program to you tonight. And I want to send special thanks to our gold exhibitors, Bristol Myers Squibb, Caris, Foundation Medicine, Genentech, Guardant, Natera, Oncosec, Tempus, and Eurogen. Our silver exhibitors are DecisionDx Melanoma and Pfizer. And I also want to thank the advocacy groups. I feel very strongly about our relationships that we have with all of these sponsors, and we have run great events, and it is so important in terms of education and advocacy and really just spreading the word to support and promote skin surveillance in hopes of preventing these these cancers and melanomas that we see. So AIM at Melanoma, the Melanoma Research Alliance, the Melanoma Research Foundation, and again, thank you for the partnership and support of our team at Fox Chase. And I want to share, our hope tonight is to share our excitement and changes in research and clinical trials and how we evaluate and treat all of our patients with melanoma. The event should last till about 7:30 tonight. And then if you have any other questions afterwards, we're more than welcome to answer your questions afterwards if we don't get to all of the questions tonight. Now I'd like to introduce our panel for the evening. Each of our panelists will take a few minutes to introduce themselves and discuss their area of expertise. I'm the moderator of the session and the MC, I guess. To start off with, I'd like to introduce Sheikh Afale. He's an assistant professor in the Department of Medicine at Fox Chase. He's a dermatologist and Mohs surgeon, and he'll share information regarding skin cancer surveillance and biopsies.
Hello, everybody. It's an honor to be here with you all. And before I start talking about skin cancer surveillance and everything, I just do want to really sincerely thank everybody, and I do want to express my gratitude and my excitement of being here at Fox Chase Cancer Center. I mean, it's just amazing to be working with all these brilliant people and to be able to collaborate with them and just come up with the best treatment plans for our patients. It's, we have these world-class physicians here, and I can just pick up the phone and ask them questions and have them see my patients. And it's just, I feel very, very grateful for that. As far as skin cancer surveillance, so I'll just briefly talk about what we do, what guidelines there are. the whole point of doing surveillance and screening is to catch things early, catch things before they become problematic or before they become harmful to you. When it comes specifically to melanoma, catching melanoma earlier is advantageous because there are times that you could catch it early enough that it will become curable or treatable with excellent outcomes. The whole purpose of catching melanoma early is it makes a big difference how deep the melanoma goes in the skin. The deeper it goes, the more difficult it becomes to treat. So potentially catching it earlier will make it much more easy to treat and have much better outcomes. I will say that the United States Preventative Services Task Force does not have specific guidelines for screening like they do for example, colorectal cancer. But that does not mean that they don't recommend screening. So the AAD and the American Cancer Society and the National Comprehensive Cancer Network have come up with guidelines to help patients in that regard. The AAD stresses self-skin exams. So we do make guidelines for patients to check their own skin to see if there are things that could be potentially worrisome. We have made guidelines that are easy to remember: A, B, C, D, E. A is so if you look at your skin, if you see lesions that meet any or some of these criteria, it may be worthwhile to have them checked. So the A stands for asymmetry. The B is border, if they have irregular borders. C is color, if they have two or more colors. D is different. The textbooks like to say D is diameter. I like to say D is difference. So if any lesion looks different from the rest of your lesions or other lesions on the skin, and it just kind of stands out, that's something that I especially like to pay extra attention to. And the E is evolving or changing. So if anything's changing, that definitely warrants some more attention. Anything is showing symptoms or growing or changing shape, changing colors, that's something that warrants more attention. For patients who have had melanoma, the NCCN actually has specific guidelines as to what kind of screening should be performed with the dermatologist. Anyone with a history of low-risk melanomas should be followed or should have skin exams every 3 to 6 months for the first 1 to 2 years, then every 6 to 12 months for 3 years after that, and once a year usually after that for most patients. With higher risk melanomas, it's the same guidelines, and in addition to that, there are recommendations to follow up with their surgical oncologist and their medical oncologist, and that is something delineated by them, by their teams. We also like to stress the importance of the role of primary care physicians in this in helping us or helping our patients catch things early. So we also like to get our primary care providers involved. As far as patients wondering whether they should have some kind of screening or not, some general guidelines are if you've had a family history of melanoma, of course, then you should have a baseline skin exam. And when we say family history, it's usually a first-degree relative. If you've had multiple sunburns, definitely it would be a good idea to have a baseline skin exam, and then the dermatologist and the patient can together come up with a plan as for routine screening after that. Other things are if there are patients who have multiple moles. The AAD says if you have more than 100 normal-looking moles, it's probably a good idea to have have a skin exam with a dermatologist. Having multiple atypical moles, so asymmetric and moles that meet other criteria to be called atypical moles, then that's also an indication or a recommendation being a dermatologist for screening and then coming up with a routine plan or a plan for routine skin exams after that. And those are kind of the general guidelines in the hope that we can catch things early again and hopefully minimize discomfort and further problems for our patients.
Great, Chet. Thank you so much. I think, I stress to all the different types of patients that I see who I'm either seeing for other cancers or my patients, how important skin cancer screening is. Because as Dr. Afali said, if we find early, that's what we want to do. We want to really, really prevent seeing these more advanced melanomas. So with that, I'm going to move to Dr. Greco, one of my partners. She's an assistant professor of surgical oncology at Fox Chase, and she's going to give a brief overview about some of the changes in how we manage surgically patients with melanoma. Thanks, Steph.
Hi, thanks everyone. And again, I'd reiterate, I'm really happy to be here. It's really a privilege to take care of melanoma patients. And, I think all of us on this call can say that we love what we do. We love taking care of patients. And it's just really an honor to be here and work together with all these great doctors and scientists and everyone else who's part of our team. So, I will highlight a couple of things regarding surgical management of melanoma. So, just piggybacking upon what Dr. Fali highlighted, obviously the goal is to find and diagnose melanoma in the early stages, because as many of you know, especially those of you who've been patients, that surgery is really the mainstay of treatment for most stages of melanoma, and especially in early stages. The treatment can be as simple as just excising the lesion on the skin, with normal skin around it, and we call that a wide local excision. And depending on the depth of the melanoma from the biopsy, the margins that we take or the rim of skin around it may differ. But that is the most straightforward procedure that we do. For certain depths, usually 0.8 millimeters or higher, we often will recommend that patients have what's called a sentinel lymph node biopsy, and that means testing the lymph nodes where the cancer may have spread to, and that's based upon lots of data from big multi-center trials that have looked at how that lymph node biopsy may affect prognosis and staging, and then future treatment. So that is something that may be warranted depending on your original biopsy result. And then in general, we also offer more aggressive surgery. So depending on the stage of disease, sometimes patients will need what we call a complete lymph node dissection, meaning if the cancer is spread to multiple lymph nodes, we may actually need to go in and remove a large portion of them. And then we also offer, surgery even in late stages. And, one of the things I wanted to highlight is in the past, when we did not have as good therapies for late stage melanoma, for, especially stage 4 and stage 3 disease before the era of immunotherapy, often surgery did not play a role in treatment of these patients. But now, because we have such good treatments and patients are living longer, and we're able to control late stage disease better, we're now often doing surgery more often for stage 4 patients and patients with late stage disease. So really, surgery plays a key role in really all stages of disease. The other thing I would highlight is, here at Fox Chase, we have played a large role in many of the important surgical clinical trials related to melanoma. So, often patients are most interested in clinical trials for medications, especially advanced disease. But we participated in several large landmark trials that have affected surgical management of melanoma. Those involve whether or not to do lymph node dissections, depending on patient's pathology. We're currently hoping soon to enroll a large surgical trial. It's an international trial that will look at whether or not 1 centimeter versus 2 centimeter margins are appropriate for patients with certain depth melanoma. Because, our goal is ultimately to reduce, the morbidity from surgeries, to try to make surgery less extensive and more tolerable for patients. So we always want to try to minimize risk, reduce complications from surgery, and figure out, the best ways to help patients, operatively. The other thing I would just point out is that, going forward in treatment of melanoma, we're seeing more of a push to use therapies before surgery in many cases. And so part of our job as surgeons is really to not only know how to technically do a procedure to treat your disease, but also to know when to time the surgery around other treatments as well. And that's why, at Fox Chase, we have a great multidisciplinary team here, and we work very closely with our medical oncologists, everyone on the team, to try to figure out when is the best time to do surgery. And again, this applies more to later stage disease, and time then around other therapies. And so we really kind of focus on that team approach. And, I would just add that we have also great resources that will help you recover from your operation. We have great physical therapists who will help you also pre and post-op as well. But again, surgery is really a mainstay of treatment, and we offer the whole complement of therapies here. The one thing I didn't mention is we also offer therapies that are not offered at many centers, such as isolated limb infusion, which Dr. Pharma is really an expert at, and that's for later stage disease, and not many cancer centers offer that type of treatment. So we really offer the whole complement of surgical management here at Fox Chase.
Great, thank you, Dr. Greco. It is absolutely, I think one of the keys that you highlighted is just the team approach. And, we meet every other week to discuss all of our patients as a team approach. We look at their slides, look at their radiology films, and really come up with a team plan, which is so key for coming up with the best strategy, and that we're all on board on how best to treat our patients. So thank you. Moving on, Jan Bueller is one of our amazing physical therapists at Fox Chase, and really helps a lot of our patients both, and I think as importantly, before surgery when we have to do extensive operations, and then afterwards. Thank you, Jan, for participating in this. You're muted, Jan. Jan, yep. Thank you.
Thank you all. Welcome. I represent physical therapy and part of the rehabilitation, which would also include OT and also speech services. Where our focus is all about function, and function can get impacted anywhere along the continuum. Our docs are great. They allow us to intervene before or in the early stages of interventions, so we can help either prepare you for something coming or actually help minimize the impact, whether it be from the surgical, the chemo realm, or even the radiation. So we deal in the entire continuum and even lifelong. For example, the radiation, there's chronic injury that can happen years down the line. If there's more lymph nodes that need to be involved or resected or damaged from radiation, that can cause issues like swelling and lymphedema. So we have programs for that. So our deal is all about some of the secondary issues. It's about function. We can deal with weakness issues, loss of endurance, peripheral neuropathy from the chemos, getting your function back, getting out of bed. We deal on the inpatient side, getting you moving again. So all the secondary issues that can happen or get compromised, that's where rehabilitation can come in. And again, anywhere along the continuum, all the way to lifelong. Thank you.
Thanks, Jan. And I really think our multidisciplinary team for lymphedema is amazing. So thankfully, we're seeing decreased rates of lymphedema. However, we have with physical therapy, physical therapists who actually are national experts in treating lymphedema, and even now procedures that can be offered through with our plastic surgeons and microvascular surgeons to actually reverse lymphedema through procedures is another thing that we offer, which is just really a step forward to just having something else to offer and improve quality of life in patients, which is so important to all of us. Dr. Chernoff is our scientific officer, and we'll discuss kind of some of the science breakthroughs that are occurring in terms of melanoma research, both at our institution and nationally. Thank you, Jonathan.
All right, thanks for inviting me here. So I'm the scientific director at Fox Chase. I also run an individual laboratory, and I've been interested in melanoma for, about 10 or 15 years now. And although I don't take care of patients anymore, I was, in the earlier part of my career, a doc who actually saw patients rather than just mice. And in those days, I saw quite a few melanoma patients. And as has been discussed earlier, it was a pretty devastating diagnosis and pretty devastating to see as a doctor. We didn't have really much to offer. We had traditional chemotherapies, which were quite toxic and very rarely curative. And we didn't really understand much about the genetic basis for the disease. And that has really changed over the last 10, 15 years. What got me into the field was in the early 2000s, all these sequencing efforts that people were making discovered the BRAF oncogene, which is present in about half of people with melanoma. That provided a target, for targeted therapy, something different than what we'd been doing before. On an independent track, people working in the immunotherapy fields began to have some successes in blood cancers and melanoma, et cetera. And the convergence of those two things, sequencing, defining what the mutations were in melanoma, plus the development of immunotherapy, has just created an amazing revolution in this disease. And that said, there's still a long way to go. With the drugs against BRAF, they are pretty good, but they generally, resistance will develop at some point, and we're now sort of dealing with that. How do you treat a cancer that initially responds and then stops responding? And here at Fox Chase, my lab's involved in uncover what pathways get activated in patients like that who initially have a great response and then stop responding. And we think we could identify all kinds of secondary targets that could be used in conjunction with the original agents or or afterwards, and also combined with immunotherapy. So I'm quite optimistic that we can get a great number of patients under control or even cured with some of the drugs that are out there already. That said, there's still frontier areas. Not everybody with melanoma has a BRAF mutation. It's only about half, so there's still the other half of people who need treatment. The second biggest mutation that we see in patients is in the NRAS gene. That's been a much tougher nut to crack, but there have been some hints of success against related RAS proteins in other types of cancers like lung cancer. So that's become a very hot area in research now, sort of going after the RAS oncogene, and that would be very relevant in melanoma if we can come up with a drug for NRAS the way that we have drugs for BRAF. So that's sort of the frontiers that I see. There's a lot of progress. There's still a lot of progress to be made, but here at Fox Chase, we have a number of labs, including my own, and a number of unique technologies that get after this problem of drug resistance that make me hopeful that we can do even better in the future.
Thank you, Dr. Chernoff. And it just, to highlight, we literally just before this meeting had a translational meeting with the scientists and clinicians just to kind of brainstorm as ways that we can improve our collaborations and communications and look to the future to find these new discoveries. And last but truly not least is Dr. Anthony Olshansky. He's the Vice Chair of the Department of Hematology Oncology at Fox Chase. He's the Medical Director of the Melanoma and Skin Cancer Program. And he will share updates on what we do medically to treat melanoma and changes in treatment. And really, he is an amazing colleague, and we all are so happy to have him to work with. And he really has become a national expert on melanoma. He sits on the NCCN panel for melanoma, and really, in terms of the revolution of immunotherapy, Tony was treating patients probably before all of us even knew what immunotherapy was, and really is an expert nationally on taking care of patients with advanced melanoma. Thank you, Tony.
Well, thank you, Jeff, for that really warm welcome. You know, it's really my privilege to be with you and all my colleagues here this evening, this early fall evening. But I was really thinking about all the sentiments that everybody's already given. You know, we are in fall, and pretty soon we're going to be enjoying a cornucopia of colors outside. And I was thinking, my gosh, we've got that in melanoma. We've got a cornucopia of different treatment options which didn't even exist. As Dr. Chernoff was saying, back in the day when all we had was chemotherapy, we certainly gave it. We wanted to help so desperately, but we really didn't think that it was going to do very much. But ever since 2011, things have opened up tremendously, and we started really improving the ability of patients to survive. So much so that now we have patients who are alive and contributing to society and living their lives without any trace of melanoma at all, even in the advanced stages, and that's truly amazing. I work at this great place called Fox Chase Cancer Center, and we have this wonderful hospital. And I'll let you know that, you know, sometimes when we give therapies, they can be toxic. I want to mention that the reason that I like working at Fox Chase is because I have these amazing colleagues, not only the people that we have here on the screen that are talking, but I have endocrinologists, and I have gastroenterologists, and I have pulmonologists, all that can help me manage the toxicities that we might see. And that's tremendously helpful. We have a giant group of nurses who know so much about immunotherapy now and so much about targeted medications. They also participate in the care of our patients, really not only from the ground when the patients are with us, but on the phone as well, answering their questions, making sure they're safe, and making sure that they're still living their lives the way they should be. We're really fortunate to have so many good therapies, and we use all of them in oncology. We now use the own immune system that we were born with to try to fight the cancer. We have these targeted medications that go after these proteins that act like switches. When the protein is changed or malformed, we call it mutated. It turns the cancer on, and we can turn it off with different drugs. We can use the immune system, as I've already mentioned, that fights the cancer, hopefully without hitting us. And we even have other drugs like oncolytics, these viruses that we can inject into the melanoma, and it actually causes the melanoma to sort of explode, I think is the best word that I actually have. The viruses sort of replicate in the melanoma and cause it to explode, and they actually can cause an immune response in and of their own. But I want to tell you that it's really the patients and the caregivers that make the biggest difference. Recently, we on this team here were the recipients of donations from patients and foundations, and we were able to purchase an ultrasound machine. That ultrasound machine lets us look into the patient's body and be able to give injections directly into the tumor. So we're trying to target our therapy not only through targeted medication, but literally putting medications directly into the tumor at the time that it's there. I have many patients who are getting that kind of therapy right now, and this ultrasound really makes it plausible or possible. So it's really so important to have your involvement in what we do here at Fox Chase Cancer Center. We treat so many patients, and I want to tell you, it's a great privilege today to be a doctor, to be able to have somebody's life in your hands, and to be able to say to them, you're going to be fine. You're going to keep on living. You're going to walk your daughter down the aisle, as I saw in that beautiful slide show that we saw, right? These kind of things are big possibilities now. And we have these amazing scientists that are looking for new avenues all the time about how we're going to crack the next nut so that we can get a little bit better at what we do. That's what we're doing every day. We have fascinating trials at the center right now. Some of these are injecting directly into the tumor. We're going to be using TIL therapy, a very novel new approach where we're not only using the immune system that a person brings to the clinic, but we're actually harnessing that immune system. that they bring to the clinic, and we'll be infusing their own lymphocytes right back into them and supporting them with interleukin-2 and other medications like that. It's never been a better time to be a doctor, and quite frankly, I think it's never been a better time to be a patient. Although I wouldn't want to wish that on anybody, it's a great place to come to when we have a problem. Fox Chase Cancer Center is filled with these wonderful colleagues that I work with day in and day out, and they have one focus, and that focus is the people who are on this call. Thank you so much.
Great. Thank you for your inspiration, Tony. Really appreciate it. And I have to say, we've witnessed together, things that we never thought we would ever see, we're seeing. Patients that, we would have predicted if you asked us that they maybe would not be alive, that are alive 3, 4, 5, 6, 7 years out from an advanced diagnosis. And we show scans in our tumor board, and we sit there amazed at what we're seeing, and that we really never even imagined we would be using the word cure for melanoma. And we love it when we can do that. So thank you. We're going to shift gears a little bit. So we're now going to open it up to the audience for questions. You can drop questions in the chat function online, and they'll be distributed. If we don't get to your question this evening, we will have a follow-up afterwards with as the event concludes to be able to answer those questions. Our first questions, and this is for Dr. I think Afali can answer this the best. What are your opinions about the use of dermoscopy, for the evaluation and screening for patients with skin cancer? And do you use it in your practice? And should it be used when you see a dermatologist? You're muted, Shek.
Yeah, that's a very good question. The short answer is yes, I do think dermoscopy has a role. I'm of course going to give you guys the long answer too. So it's.
Can you briefly explain what it is?
Yeah, so dermoscopy is actually it's a little handheld device. It has a magnifier and it uses polarized light. So the polarized light allows us to look beyond what's called the stratum corneum, which is the topmost layer of the skin. It's basically, it's mostly made of keratin, which is like a skin protein. And the dermoscope or dermatoscope allows us to look a little bit deeper than that layer of keratin. So it's supposed to help us identify structures or identify lesions that have involvement in deeper parts of the skin. I do use dermoscopy actually almost all the time. I will say it's more of an aid, and it's not a perfect science. It has definitely helped me identify lesions, and which ended up being malignant. I will also say there are times that the most important thing, though, is just a gut feeling. Now, there have been so many times when I have seen a lesion and I look at it with the dermatoscope, and I kind of go through the list. Does it meet this criterion? Does it meet this criterion? Does it meet this criterion? Because there are specific criteria that we learn with the dermatoscope. There have been many times when the lesion does not meet any of the criteria, and then I'm supposed to, I guess, just say that, oh, it's benign, but my gut feeling just kept saying, no, it just doesn't look right. Something about this does not feel right. And then I biopsy it, and there you go. It ends up being a melanoma, early stage, which ended up being cured with just a small procedure. On the other hand, I will also say it has helped me identify lesions where I say, I don't know, I don't have a real gut feeling about this. I'm going to use the science now. I'm going to use the dermatoscope and look at the criteria, the specific criteria. And there have been quite a few lesions, especially lesions on the hands and feet, where I have been able to identify things that clinically, or I should say, just to the naked eye, that they didn't look like much. But then when I used that dermatoscope, I was able to kind of see those atypical features and then biopsy, and then it ended up being early stage melanoma. I was especially happy about catching that latest, foot melanoma, because I used the dermatoscope for it, and and we caught it at a very early stage, in situ, basically, which means it's just in the top layer, confined to the top layer of the skin. Whereas many people with hand and foot melanoma, it's diagnosed quite late, and quite a late stage where treatment becomes difficult. Thankfully we have more treatment options now, but still, it's always better to catch them earlier and be able to just remove the entire cancer. So in that instance, dermoscopy was amazingly helpful. So I'm sorry, I'm not able to give you like a 100% yes or no answer, but hopefully that kind of clarifies things.
I agree. I think it's another tool that, just like anything else, it could give us another viewpoint in evaluating patients. It's not 100% a necessity, but it definitely can add to the physical examination sometimes. And so I think it's an important tool. Next question is, can we just speak about bioassay repository programs in respect to melanoma patients? I don't know, Tony, if you have any thoughts on that.
Yeah, I'm happy to share my thoughts. It's actually the biosample repository. And basically what that allows us to do is collect specimens from patients who are already undergoing surgery. So typically, if you need surgery for something and you come to Fox Chase, we're going to approach you and ask you whether or not we can collect tissue. We're collecting both normal tissue as well as anything that might be malignant. It's so important to be able to contribute to this source of this rich resource, because we then can use that information, that tissue that's in the biosample repository, to do science, right? To do this amazing science. Physicians like Dr. Chernoff reach into the biosample repository all the time and use some of this tissue, both normal and malignant, to really answer critical questions. And what's so amazing about this particular repository is it's hooked to clinical data. So we can sort of know what was happening to the patient at the time that we got those samples, and yet we don't know who the patient is, right? It's completely de-identified. So it's completely safe to contribute to this. We'll never know who it was that contributed, but we'll always be thankful because we can do this amazing science and discovery. John, maybe you have a few words you could add.
Sure. So we do a lot of fundamental work, and we here at Fox Chase and also scientists around the world, we do a lot of this experiments using mice and other what are called model organisms. But at the end of the day, you need to know whether the things you're discovering are relevant in human melanoma. And since you can't do the sorts of experiments with people that you can do with mice, these tissue resources like the repository are absolutely critical. So you can test a theory that a certain protein is important in melanoma, or that a certain therapy does X, Y, or Z, and you can use these patient-derived materials to get those answers to then get you much closer to figuring out whether your ideas are relevant in the human setting, which is of course what we all care about at the end of the day. So those donations of tissue and blood, etc., are absolutely critical, and we obviously appreciate the cooperation of the patients in making those donations.
Yeah, and I would highlight, almost all of our patients are asked about our biosample repository. And we also, just from a safety standpoint, only use additional tissue that's not going to change any information we need to treat the patient. So we make sure that we've made the diagnosis, that we have all the information we need from a clinical perspective before any of that tissue gets banked and stored. And this has been ongoing. Jonathan, how long has the biosample repository been present?
Oh, in some form or another, but it goes back more than 30 years. And it's actually one of the best repositories in the country. There was a rating done by the NIH some years ago, and I think we were considered second or third best collection in the entire country.
Yeah, it's amazing that the foresight to think to, start doing that and how much it's changed and how important it is probably back then it is as it is now.
And it's not, divided into departmental collections. Many universities and medical centers have collected tissue, but it belongs to the renal surgeons or the GI docs. At Fox Chase, it's always been one unified tissue bank that anyone within the institution and even outside can get access to.
Great. This is a question, and sorry you're highlighted, Tony, but the question is, I had BRAF testing, but in the packet for this event they received, there were pamphlets for additional tests from Tempus, Guardant, Signatera. So there's a lot of new molecular tests that are coming in the market. Is there a necessity to get further testing, or when would you recommend kind of doing additional testing if you already had molecular profiling?
Yeah, that's a great question. Right now, the most relevant marker that we really have is BRAF, because we have drugs that specifically target that pathway. The MAP kinase pathway is what we call it scientifically. We have drugs that target BRAF and a different protein called MEK, and we typically use those in combination. But most of the testing that we do also tests two other important proteins. Dr. Chernoff mentioned one called NRAS. And for a few patients with melanoma, we also look at c-KIT. And then very rarely, patients can have other important mutations. But the truth is that about 40% of patients have this BRAF mutation. Very few actually have a c-KIT mutation, and even fewer have something called an NTRK mutation. And so we don't have a whole lot of medications that we can use for melanoma in the targeted area just yet. And so when we're running a large panel, and we typically do something called next generation sequencing, a large panel, it provides us with important caveats about the melanoma, like the tumor mutation burden and other mutations. But realistically, there's only a couple different things that can actually target it. And so, I think that right now there's a lot of science going on about whether or not some of these other tests will become useful or not. We do use very occasionally blood-based tests as well to do this next generation sequencing if we cannot get a hold of tissue. Now, with melanoma, that's typically not a big issue. We typically have a lot of tissue that we can work with, but if we can't, we can always move to the blood-based banks as well.
Great. So, I think in any of these situations, I think it's most important to discuss with your treating physician about kind of if they think further additional testing is warranted. And, the goal of that testing would be to open up other treatment options for that patient. So I think that's a discussion that could be had, especially if you're looking at kind of additional treatments or therapies. Acral lentiginous melanoma. So these are rare tumors that can occur on, as Dr. Afali was saying, on the feet or in the palms, and tend to present at a later stage and tend to be more aggressive when we see them. It's not to say that you can't find these earlier, but in general, they tend to be a little more aggressive. The question was, are there any current studies regarding decreasing recurrence reduction with immunotherapy in these patients? Tony, do you want to talk about that?
So, we do have some new approaches that are actually being investigated very much right now, something that we typically call neoadjuvant therapy. So when a patient goes to Dr. Greco or Dr. Pharma in anticipation of surgery, sometimes we have the ability to give therapy first. And that therapy really has two main goals. One is to actually make the surgery a little bit easier for the surgeons to be able to clear the area of all cells of melanoma. And secondly, we think that there's a good correlation between demonstrating an early response with immunotherapy and having a long-term good outcome. Now, this data is just beginning to come up through the clinical trials. It's not yet an approved approach, but we are fortunate enough at Fox Chase to have clinical trials that actually use this technique. In fact, Dr. Pharma is one of the leading investigators in using a technique just like this, where we inject a tumor with two different therapies that stimulate the immune system at the site of the cancer. And then the surgeons can go in and take care of it afterwards, after we've given a couple injections. And we're finding this approach very favorable. I do think that sometime in the future we'll have an approach like this that we can offer to all patients if it becomes approved.
Great. The next question was, can we talk about genetics and how that factors in a person's risk of developing melanoma? Maybe Dr. Greco, do you want to talk about, do we refer anyone to genetic testing, or are there patients that kind of the most common risks that for developing melanoma?
Sure. So, that's a good question as well. So, obviously for across all cancers, there's been really an increasing push to refer patients for genetic testing across a variety of cancers. Most of you know, specifically in breast cancer, now in other cancers as well, colorectal and pancreas cancer. In general, anytime any one of us sees any cancer patient, not just melanoma, it's important we take a very careful family history, of patients, mainly immediate family, to see what kind of cancers, run in the family, and not only if the family member had cancer, what age they were diagnosed. It's very important when considering whether or not to refer somebody to genetic testing. So that's really an important process of your initial meeting, not only evaluating for the diagnosis, the treatment, all of the staging of the cancer, et cetera, but also the family history. In general, I think, most of us, if we see a patient that's had 3 or more, so what we consider a large number of melanomas, so someone who's had 3 or more skin cancers or 3 or more melanomas, that's somebody we would consider referring to our risk assessment. And we have a great program here that's extremely experienced, and will take it one step further than this initial visit. And they'll really know when it is or is not appropriate to refer somebody. And the reason that's important is because oftentimes you may get results that are hard to interpret. And so often patients may go for testing, and then they will generate a report that says they have a mutation basically of unknown significance. And this is a common thing that comes back in the report. And then patients can often become, confused, concerned, what does this mean? And in reality, it means we don't know how to interpret it, or if it has any prognostic or therapeutic meaning. And so it's really important. We want to make sure we refer people properly. We all know that, the biggest risk factors for melanoma are, previous sun exposure, so sunburns, and this can go back to, many years before the patient is diagnosed. So, often we'll see patients who come in and they'll say, but I don't go out in the sun, at all. Why do I have this melanoma? It could be you had a sunburn 30 years ago as a child, and now developed a melanoma later in life. But, so those are really the main risk factors, but we do have a great risk assessment program here.
Yeah, and I would highlight, so about, less than 10% of melanomas are probably related to a genetic reason for having them. And there are some links, in addition, if you have a family history of someone who had pancreatic cancer, breast cancer, ovarian cancer, and melanoma, there may be a link between those types of cancers. If you personally have had a lot of multiple melanomas, as Dr. Greco said, or if a lot of your family members have had melanomas, we will consider genetic testing. And that could, if we identify a gene, we don't do for melanoma specifically, we just increase screening, seeing the dermatologist, and identifying things early. But if we find a specific gene that's linked to another cancer, we may be able to screen for other cancers, like pancreatic cancer, which we don't routinely screen for. So I think it's really important if you had these kind of risk factors to consider genetic testing. This is also for Tony, and then we'll have one question after this. Can you speak a little about, are there any changes in the treatment of ocular melanoma or new treatments that are upcoming in terms of ocular melanoma?
Sure, that's a great question. There's really 3 sort of facets about melanoma. One is sun-exposed melanoma, like Dr. Greco was talking about, that typically happens on the skin that we can see. There's also a different form of melanoma, which is much more rare, called mucosal melanoma, which actually can happen along mucosal surfaces inside the body. And then the third melanoma, which is even more rare, is ocular melanoma, melanoma that begins inside the eye. And while we do treat those patients pretty aggressively with surgery typically or radiation therapy to the eye, it unfortunately has a consequence of leading to blindness in that eye. And some of these patients will go on to develop worse disease. Unfortunately, we haven't seen some of the same robustness of our responses that we've seen in some of the other melanomas in ocular melanoma. But that doesn't mean that they don't work. We've used immunotherapy in ocular melanoma and have had some good responses in patients. There's a lot of research currently going on in ocular melanoma. We again don't have very many targeted therapies in ocular melanoma, and that's what makes research so incredibly critical. We want to be able to provide a lot of clinical trials for patients with these types of melanomas so that we can learn more. So we're still in the learning process. It's a different kind of melanoma, but I really do think we are making some headway. We've done a research trial recently at Fox Chase Cancer Center and shared also with Jefferson, where they're doing a similar trial in ocular melanoma with some pretty encouraging early results.
Related to ocular melanoma, I think it's really important that you're just seen by a team that specializes in seeing patients with, it's a rare tumor, and uniquely, unlike cutaneous or skin melanoma that can really spread, unfortunately, anywhere in the body, ocular melanoma has a propensity just to spread to the liver. So you have to make sure if you are diagnosed with ocular melanoma that you're screened appropriately and undergoing staging studies that include evaluating, making sure there's no evidence or developed evidence of spread to the liver. So with that, this is a very interesting question. And just briefly, this is, we'll go through the whole panel. If you were to blink and have, and be 5 years in the future, thankfully, hopefully we'll have a COVID vaccine. What are some advances in your field that you're hopeful you will see or wish for? You want to start, Dr. Greco?
Yeah, that's actually a really interesting question. So going first, I have less time to think, but you know, I think in terms of surgery, as I kind of alluded to before, you know, we're hoping to offer patients, you know, the least invasive, the least morbid operations possible that are at the same time equally as effective, or if not better, more effective, for example. And so, you know, part of that involves, you know, better ways to kind of detect microscopic cells. So there are some advances coming through the pipeline in surgery in general that are aimed at better techniques to identify tumor cells in the operating room that are not visible to the naked eye. And this somewhat goes back to the dermatoscope that we were mentioning before. But there are technologies coming out that would allow us to actually see microscopic cells and therefore allow us to know where to cut out the tumor so that we've cleared it completely without having to take extra tissue that creates more functional deficits or more cosmetic deficits and things like that. So I think that's definitely an area that across cancer surgery in the next 5 to 10 years is going to be coming down the line. And again, the whole idea is to then really reduce, you know, the effects of surgery that can, you know, either affect function or and outcomes overall.
Jan, what would you wish for 5 years from now or hope for? You're muted again, muted.
Okay, since my role is definitely like a result of what you guys do, I'm just hoping for bigger and better medical and surgical advances with smaller and smaller functional deficits as secondary to those issues. And the more you guys are doing, which I've already seen progress in the 20 years I'm working in this field, I just hope that continues.
Thank you. Dr. Chernoff?
Yeah, I hope that in the next 5 years, we can do for the other half of melanoma patients what we can do for those that have BRAF mutations. So I think if we can get a therapeutic for NRAS and some of the other rarer mutations that people have talked about, that would go a long way towards you know, improving outcomes for patients.
Dr. Fale?
Yeah, I echo the sentiments of everyone who's spoken so far. We're always in a constant quest of just making that, diagnosis easier, making treatments better and less harmful to patients. And I feel very hopeful. I mean, I think there are a lot of very good and exciting ways of diagnosing things and ways of treating things coming up, and immunotherapy is an excellent example of that. And I think we're just going to keep building on what we have built so far, and I think the future is going to hold a lot of promise for our melanoma patients.
And Dr. Olshansky?
Yeah, I guess I'm kind of greedy, because what I want most in 5 years is to be out of a job, because we won't have to treat anybody anymore. And that would be really wonderful, right? And so I want to just put a plug in for the way that we get there easiest is by prevention. It is so important to try to prevent this terrible disease in the first place. So, I'm an older guy already. My job is to try to keep my kids safe and try to keep their kids safe and try to keep their kids safe. That's really our job today. If I really had something I would pick on, immunotherapy is great. It works well, but it does have some side effects, and that's primarily because it's not completely directed yet at the melanoma. We're developing those technologies right now, but I'm hoping that in 5 years, when I give immunotherapy, I know exactly what it's going to attack and when it's going to attack. That's what I'm hoping for.
And I can share. So, I think that what I want to continue on the trajectory that we have, because I think that we've come up with amazing discoveries, but I really think we're at the beginning of the discoveries. I think that I want to see more where we have, really two main standard of care agents for metastatic melanoma. That should be 5 or 10 that we have in our pocket that all work and have decreased side effects, that we can improve the quality of life of our patients, and that we can increase that cure rate that I spoke of earlier, because I think that's, we never thought we would even be talking about cure in melanoma, but we have to increase it now. And so that's what I would hope for. With that, so I'm going to introduce George Beshin. I work with George all the time and can really at this point consider him a friend. He works in institutional advancement, and he was just going to give a brief message. Thanks, George.
Sure. So how wonderful are these people? And I'm talking to everybody watching us on Facebook. It's my privilege to work with all of them, with uniting them with other wonderful people, and that is our donors who gave us last year gifts totaling over $17 million. So I just wanted to put in a pitch. If any of you are ever curious about the process, if your gratitude leads you into that direction of wanting to donate, it's very easy. And I made a sign just for you. Give me a call. We can talk about the possibilities. We could talk about these wonderful people that you and I know. So with that, I'll give it back to Jeff. Thank you.
Thanks, George. Your sign comes up in reverse, but we'll make sure everyone has your number.
Oh, no.
So thank you, George. That's our time for the evening. I really appreciate each and every single one of you for tuning in and spending the evening with us. We hope that we answered some questions and provided insight into why we are passionate about treating patients with melanoma and excited for working in this disease space and hope to see advances in the future. I again want to thank all of our exhibitors and advocacy groups, including CARES, Foundation Medicine, Pfizer, BMS, Genentech, Guardant, Natera, Oncosec, Tempus, Eurogen, DecisionDx, Sanofi, Regeneron, and all the advocacy groups that I really so enjoy working with and helping and participating in events. I know that a lot of them are virtual now, but I so look forward to going back to the live events where we can see our patients and families together in an environment that's outside of the hospital. I want to thank my colleagues, Dr. Afale, Dr. Greco, Jan Bueller, Dr. Chernoff, and Dr. Olshansky for just working with all of you. I think it's such a special place to work at. Fox Chase, I think we all stay at Fox Chase because we love the colleagues, as we all said before, and who we work with. There's upcoming events coming, the Together Facing series from Fox Chase. If you have anyone who has an interest in learning more about bladder and kidney cancer, breast cancer, lung cancer, pancreatic cancer, and blood cancer, there will be events coming up this fall and into the winter. I hope we can all stay safe together in person. I hope that we move forward out of this 2020 dilemma. But we need to just stay focused and look at the positives that we've all seen, even in the pandemic. So thank you all for participating. Good night and take care. Thanks, everyone.